All right, why don't we jump in? Thanks so much, everyone, for taking the time to be with us this afternoon, this morning. Really appreciate it. We're excited you're here. My name is Max Dalury. I'm the Vice President of Analytics and Revenue Operations here at PayZen. I have over 15 years of experience in healthcare consulting and patient access and tech. I've been at PayZen for just about 2 years, and a core part of my job is leading all of our data and analytics conversations with partner systems, partner organizations, HFMA. And today we're here to talk about key findings from the provider perspective report from 2026 that we did in partnership with our friends over at HFMA. The theme here is the patient is now the payer. Real focus is on rising patient responsibility, becoming a frontline revenue problem, whereas we've really focused on commercial and government payers historically. So I'm going to spend about 40 minutes walking through our findings. We will then jump into a live Q&A at the end. You should be able to see down at the bottom of your toolbar a question and answer section. Please drop those in. We will come back to them at the end of our time. We will also be sending out the recording for this link after the fact, so keep an eye out for that. As we take a look at what we're going to cover today, we've broken this out into a couple of different areas. So what is the reality for patients, and why does this matter? We're going to talk through the methodology, how we ran the report, and ultimately we've broken this out into a couple of different sections where we really saw core focus come through from respondents, and that's really the need for earlier financial engagement and how that's our reality today. The real critical gap that exists in patient payment options today, and the requirement that we all have to continue to invest in that space. And then also a bit of a deeper dive on where systems like you all are using AI in the revenue cycle, with some early focus on pilots and early recap. So the goal today is not just a recap. We want this to be a benchmark for yourself. Come away with, hopefully, with the right questions as you start to think through how this resonates for your organization and your system. So let's start with the macro picture today. The ground's really shifting underneath patients' feet, and it's showing up in the revenue cycle. And there are primarily two major forces that are converging here. So the first is the evergreen adoption and kind of growth of high deductible health plans. A full third of all covered workers are in a high deductible plan this year. At the same time, those average deductibles have increased by about 43% over the past decade, and family premiums are all the way up to $27,000, a 6% increase year over year. And this isn't just limited to individuals as well. This is hitting employers. There's some data to show that average increase for employers was about 24% in their premiums as well last year. So this is a systematic driver in the increased costs that we're all seeing. The second major component is the changes to Affordable Care Act subsidies. Many of those supporting funds have expired at this point. We've already seen 1 million fewer marketplace signups in 2026 versus 2025, and 114% average premium increase for those subsidized enrollees. And this is the reality, unaffordable for many Americans. There's been a significant downgrade effect that we've seen start to manifest. So silver plan signups fell from 57% down to 43%. That's a record low. And the move to bronze plans has resulted in a higher out-of-pocket exposure. At this point, the average single ACA deductible is $3,800 in 2025. So the real question here is, affordability is not a social good conversation. It's a frontline revenue cycle issue as we've transitioned the burden of this cost over to individual patients, especially amidst a challenging macro environment when we look at inflationary trends historically, where interest rates sit today. And really, this report measures that in a good more detail. So let's talk about what we actually did with HFMA. This report went out to about 200 revenue cycle leaders. It's a 35-question survey that we did in partnership with HFMA. We looked across net patient revenue swaths. So the floor in here is $200 million. This is new relative to last year when we did this. We didn't have that floor. So our average net patient revenue for systems has increased a bit. So when I talk about year-on-year metrics, those are supposed to be directional, not gospel as it relates to actual performance, but we do believe it's indicative. And we had respondents all the way up to $25 billion net patient revenue. So we think we have a decent perspective from across the size gamut. It covers financial performance, financing, pre-service practices. We'll walk through all of this in a bit more detail. So let's dive into it. And we're going to start with where patient balances now sit for respondents on their priority list. And this was ultimately the largest shift that we saw in priority in the report. So the share of those individuals who ranked patient balances as their top revenue priority nearly doubled. Went from 11.4% up to 22%. It's a 92% increase year over year. Now, commercial revenue is still far in the lead at 62.2%. Patient balances have not and will not replace that. The signal here really is the slope. So it's the fact that as leaders sat down and thought about this, that rising responsibility is top of mind since it's manifesting in collections numbers, in increased bad debt placements, in overall affordability concerns, and a lot of the conversations that your access teams and counseling teams are having with patients about how they can continue to afford care at systems. So if it's a priority, the question then becomes, do we all know how we're actually performing? How is this resulting in what systems are actually seeing today? So let's take a look at some of the benchmark data there. These are comparison points. They are elements of a benchmarking tool, again, a pure average off of all of the responses that we saw through the survey, through those 205. Again, there's very wide dispersion in here. So this might not look exactly like what you're seeing today, but hopefully this can be directional as we think through it. So across respondents, 12% of net patient revenue were billed to patients as their responsibility, either true self-pay or balance after insurance. And we saw that number get up as high as 30% for a couple of folks. So again, a pretty wide spread here. 31% of those dollars billed were collected on average, which is kind of an astounding number. Any other industry, 31% would be unimaginable. This is not somewhere in retail. They're not seeing 31% collection rate. So this is kind of this remarkable, this eccentric reality that we're living in today that is challenging the industry. When we actually looked at how those collections were manifesting, 21% of those you all reported or respondents reported as coming pre-service. This is very much obviously focused on the services that are scheduled, elective in nature, where we see a lot of that concentration. About 23% of patient collections are made off of payment plans today, and that's been growing pretty significantly as well. And then about a point of net patient revenue across all respondents is tied up in patient payment plans today. So those are dollars that are going to sit out there for as long as as patients are actually scheduled. So generally speaking, months or years in the future where you're unable to deploy them internally today. So as we think about the questions that I'd encourage you all to consider now, and as we go through the rest of this presentation and take back to your teams, how do you compare to this? Do you know your true collection rate for patients as you look through that waterfall of net patient revenue, dollars actually billed to patients, net of discounts, how much that's actually being collected? What percent of your revenue today, as well as revenue potential in the future, are currently constrained? And then how is this manifesting in aging, defaulting dollars, uncollectible balances? And what we really took a look at was how are systems responding to some of these headwinds and the collection rate in particular. And as many of you know, it starts before the visit. The big shift is that money conversation has moved so far upstream. And there are a lot of different publications and pieces out there showing, this increase to as high as, I think the high 60s, 27% of dollars pre-service. I think, obviously our average was a little bit lower, but this is the reality and a big part of how those patient balances have climbed up the agenda for systems. So pre-service engagement is now the standard practice. 92% of respondents encourage payment, require a payment, or are collecting a payment method on file during the estimate pre-service. That's up from 81.3% last year, 13% increase year over year. In the debate over whether to engage early is done. This is the reality for systems today. It is industry best practice. It comes up in every conversation that we have externally. The open question really is, how is this done? How are organizations and systems doing this without unnecessary friction or driving care avoidance? The reality is, if your patient is balking at a $500 down payment, the last thing you want them to do is showing up in the ED 4 months from now with a $7,800 bill that we all know they won't be able to pay. So the most important thing to have done right here is provide more time, greater clarity, and options to support the patient. So the proactive collections path is critical, but the reality is that earlier engagement does actually have a cost and can drive into significant care avoidance as well as staff load issues internally. So we run a separate report that we can also send out through a webinar recording as well. And that's a patient perspective report, very much focused on patient affordability. How do they think about what they can afford? How do they think about the family decisions that they have to make? And from that report, we saw nearly 40% of patients delayed or skipped healthcare visits due to cost in 2025. And this really kind of pulled at my heartstrings a little bit. A full third of patients responded that they delayed care for a child because of healthcare costs. And I mean, even personally speaking, this is something that I've dealt with recently. I have a couple of boys. My oldest had an ear infection a couple of weeks ago. Went in, we said we needed antibiotics. They asked us to come in. Shortly after the visit, I got a $500 bill, $450 patient responsibility. 10 days later, ear infection came back, called, asked for more antibiotics, told we needed to come in to be seen again. Another $500 bill with $450 patient responsibility. Now, I have a lot of experience in healthcare. I'm going to ask if the 99213 is the right code for that type of a visit, or if it really merited that charge level. But the reality is, a lot of people don't know to ask those questions, or aren't going to, or are just going to be so stunned by a $900 bill, which I'm lucky enough I will be able to figure out a way to pay that, but that is unaffordable for the vast majority of Americans. As all of these conversations happen and the pushback to access teams, to financial counselors, their workloads rise significantly. We're already critically focused on estimates and getting those out the door timely and accurately, and continuing to expand financial assistance screening, especially when we see the fragmentation in approach across states for those organizations that are working across state lines. There's the obvious Medicaid eligibility question, and that's continuing to change with updates to federal regulations. And we've got plan talks, our coverage education, patient outreach. So this carries a real weight in OpEx for the systems. So the question's really not about do you collect earlier, it's how to do that without driving avoidance and in a way that's ultimately going to be efficient for systems. And the answer really is pairing the ask for prepayment, for down payment, with affordable pathways for patients. So since we live in this world where pre-service engagement is now the standard practice, the debate is really over, sorry, I jumped right ahead. Affordable pathways beat engagement alone. We have to have that solution for people. Since pre-service collection rates rise when the policy pairs with an affordable option, for those who had that effective strategy, 5% of patient billings were collected pre-service versus 2.4% with no policy in place. So doubling, that makes a ton of sense, right? But we saw this real divide between large systems and smaller systems. So the larger systems nearly doubled collections of smaller. Makes sense again. They're smaller systems less likely to have the pre-service policy or the structure in place to educate patients, to govern, and to make those decisions collectively. And the critical matter here is that patients need a realistic way to pay for that bill the moment the estimate lands. And this is where tools like pre-service financing come into place. So be it in-house payment plans, be it tools like the care card that PayZen offers, it's all about clarity for patients, plus a practical next step that they could actually take if they can't afford either the fully required deposit, the down payment that you're requesting, or at least getting a payment method on file, since that's critical to make sure that it's a cleaner journey from a collection standpoint. The reality, though, is that the collections policy itself is not enough to move the needle. As those pre-service collection rates have increased, 68% of systems have indicated that they're going to proceed with that service, with that care, regardless of if a patient is able to pay. And this makes sense, right? This is not a compassion problem. No one is doubting that our healthcare systems are laser focused on patient care, patient outcomes, treating populations the right way. They'll always care for their community. It's a tooling problem. So the opportunity here is to move from a question of financial clearance to financial navigation. It's not just a number for people to react to, but a path to follow, as we know that these collections are going to continue to be a critical step. It's just the reality of how we're operating. And you all have indicated that you want this to start even earlier in the process. We're simply too far downstream already as it stands today. So this is one of the things that jumped off the page to us when we took a look at how diametrically opposed respondents felt about where we are today versus where we want to be in the future. So there's this huge gap of where this is happening. 61% believe that Medicaid and financial assistance screening should happen at scheduling. The reality is only 20-ish% are actually screening there today. And just 3.6% of respondents believe that screening at the visit should be the future standard. It's simply too late. Expectations have been missed. Results in frustrating, challenging patient communication. So it's the clearest view that we saw in the data of where we are today versus where we want to go in the future. So I'd encourage everyone to think about, how are you doing this today? When are you screening? Is it early enough in the process? How many eligible patients that should be having this conversation are actually having it? And what are the patient access initiatives, the core engagement initiatives that would actually make that a more reasonable or a more consistent experience for folks, so that they aren't surprised when they come in through different pathways? So that's an overview of engagement. Now let's jump over to the payment options themselves, since they're falling short relative to what patients are saying they actually need today. Let's start with the mismatch as it's structured and that kind of flowed through the results. So the reality is, in-house payment plan terms today are generally far too short for the balances that exist right now. 6 in 10 hospitals cap their in-house payment plans at 24 months or less, and a full just about third of respondents are 12 months or less. 16% of systems under $1 billion in NPR don't offer any in-house payment plans at all. So balances are rising quickly. That patient responsibility talked about continues to go up. The terms that are available to patients, how long they actually have to pay, are not. So there's this structural affordability gap that exists today and is continuing to widen. which is ultimately manifesting in a revenue performance gap. It's going to continue to put a lot of pressure on those collection rates. So thinking through how this lands for you today, what are the average terms that you're offering? Are they long enough? Are they flexible enough? Are they being offered consistently to patients, especially those who are not quite eligible for financial assistance but are right on the borderline? Another key question is who's declining plans? It's a really interesting place to look at. I'm trying to give patients an affordability tool, but they simply can't make it work. That's a structural issue that's manifesting there. And what happens to those patients who need longer? Is there a process for them, or are they just flowing through the rest of the dunning process and landing in bad debt? So let's take a look a bit more tactically at where this mismatch exists today in dollars. The math simply doesn't work. Patients indicate that on average, they can afford $82 a month toward medical bills. So let's take an example of a $5,000 bill after insurance is processed, patient responsibility. That's more than 5 years. We just talked about how majority of systems cap at 24 months. So when those terms don't match a patient's ability to pay, it just directly goes to an increase in defaults. Those balances stay unresolved, longer days outstanding. This is really like the crux of this affordability and revenue performance issue that is only going to get worse as patients continue to bear more and more responsibility for balances today. And the tricky part is most systems today don't even understand how those payment plans are performing internally. And this is a conversation that I have externally all the time, both with prospects, with partners, with industry partners. This is a true performance visibility problem. Many of you are on Epic. Epic does a phenomenal job of reporting across the board. However, when we look at the complexity that goes into payment plans, it's really hard to get it accurate and bulletproof relative to how these are actually performing. So think a plan that was originated, a second payment was rolled into that, then insurance was reprocessed, so the balance went down. There might have been a write-off or something in the middle. Each time, frequently those are cycling through, and it's really difficult to link to that original balance and understand if I originated $1,000, how many of those 1,000 did I get back on a per patient level? It takes a significant amount of reporting work. And our respondents acknowledge that. More than 70% said they do not know their in-house default rate on payment plans longer than 12 months. For those that think that they do, from firsthand experience, frequently when we take a look at it, we can find some pretty significant holes in how they think they're performing versus the reality because of some of those structural data issues. And all of that is just collection rate, right? So yes, it's great that dollars are paid, but there are real structural costs that drop to the bottom line and impact overall unit economics. So think payment processing, generally 2%. Think about the cost of capital for having a plan tied up, for having cash for a plan tied up for 3 years. Think about the OpEx of getting patients signed up, of calling for late payments, of answering questions and having to manually touch plans. That can be a couple of points as well. So it can be very difficult to monitor the performance of this and can oftentimes be a blind spot for a risk area. So I'd encourage everyone to think about, do I know my collection rate? Especially for those longer term plans, since that 12-month mark is really where we start to see delinquencies aggressively increase. How much of your revenue today, of how much of your total collectible dollars are tied up in active plans, and what are some of those underlying pieces? And critically, is there agreement between executive teams and operational teams of what this looks like? Because can be a surprising delta in perception versus the reality of how challenging many of us know this can be to administer today. So it's no surprise where the market is heading. There's been a significant pivot. 1 in 2 systems now work with a third-party financing vendor. So 15% increase year over year. And amongst those adopters, 36% grant cash acceleration. So that is taking those dollars that are tied up in long-term payment plans and bringing them in earlier so that you can deploy them against other initiatives, put them to work for you sooner. That's their top priority. So we're near this tipping point with nearly half of systems having shifted over. Adoption continues to accelerate. And it becomes this pulling factor, right? So long-term affordability for patients with better cash flow and less balance sheet risk, we expect this trend to continue. So switching gears a little bit into the other kind of elephant in the room, if you will, let's talk a little bit about what we learned about AI in the revenue cycle today. It's moved from curiosity into action, and the numbers have moved really quickly here. So Gen AI is no longer this hypothetical element in RCM. 1 in 3 systems are already using it today. 48% of large systems, call it $1 billion in NPR and plus, already are. And those large systems are about twice as likely to use AI than the smaller systems. 85% of respondents said that they are either interested or very interested, and they're all watching all of these pilots to get a clearer read on how do I separate the signal from the noise? Where are we seeing those higher returns, especially with the huge flow of new technology, the ease of getting some of these pilots stood up, the competitive interference that some of them are having with each other. Everyone's looking for a clearer view of where is the most value, how do I double down on this, and what are the places where it's ultimately ready for prime time. So we've seen these early activity clusters and denials, coding, ops. Obviously, that makes a ton of sense when we think about the priority being those commercial payers, top priority for our leaders. The patient financial journey, though, is that next frontier. And use cases are already starting to split up by system size when we think about the structure there. So smaller systems maintain that focus on operations. The larger systems have already started this transition into patient-facing. The patient access initiatives, scheduling and exposing that to patients in self-service. There's been a lot of funding activity recently that we've seen in the news, as well as some really exciting early outcomes as we see these tools allowing operational teams that are already stretched to the max to be more effective and to provide a more consistent experience for patients. This is also manifesting in financial assistance, something that PayZen's taking a look at as well, and for call center teams. So as this earlier engagement continues to scale, AI makes it more personalized, more proactive instead of manual work. And we expect teams to continue to kind of peel back the layers on what are the drivers here? What are those solutions that make the most sense? Who are the winners that we want to invest in? And ultimately get that confidence that this ultimately is driving the right type of benefit for your organization, but also for patients. So the positive experiences that patients are having with this technology, validating, verifying that that's actually real and that organizations are comfortable making that investment is a core enabler to this broader adoption. And we think that we're seeing that happen today. So as we step back, I've been talking for almost 30 minutes at this point. We see 4 major themes that are converging through the survey, specifically on the patient financial engagement model. The first is affordability. So patient costs are changing behavior. We're seeing care avoidance risks. We're seeing systems having to behave differently. But these are key questions around how do we set up access in the right way? How do we keep a open, as frictionless as possible access policy? How do we do it in a manner that encourages and builds trust with patients and in a way that can be predictable so that when people are sick, when people need care, when you need to go see your doctor, patients have an idea of what's going to happen and aren't surprised time after time. They need to understand what that new reality looks like for them and plan financially accordingly. The earlier engagement piece of that is a huge part of that conversation moving upstream and really falls into that trust piece as well, right? And allowing people to be structured and ultimately follow through on their care. And as we see this AI-enabled scale, we're really personalizing and automating that patient financial experience, consistency, ease of access, lower handle times for teams, the ability to self-serve and understand the full breadth of offerings that are available for them. But across all of these three pillars, visibility is key. How do I get clean reporting and a clear perspective of what is driving the highest return on investment for my spend? What are the KPIs that matter most to me, to my peers, to my leadership team? And how do I have clean and consistent reporting so I can see that value, so I can see where things are working and understand where there are challenges and tackle them before they become kind of these endemic problems that are really hard to unwind. All these together, we believe, are this blueprint for this new era of patient financial engagement. And we're really excited to continue our partnerships and our surveys and our conversations externally in the market to understand how that's continuing to shift. So we'd encourage you to take this diagnostic, listen to, kind of the key questions we encourage you to bring back to your team, and spend some time thinking about how this can be a guide for you all to consider where you are in that journey. So do you know your true patient collection rate? That focus on longer term payment plans to match patient affordability, and is there a clear perspective, a clear understanding of that default risk so that you can plan accordingly for it? Does it match what patients can realistically afford in your particular area? Are you consistently getting to those patients with financial counselors so that they can get the support that they need? And are we engaging them early enough with options that actually match the estimate or the responsibility when it does land? On the AI front, is this just an efficiency play, or is it actually improving that patient financial engagement as well? The goal we'd encourage all of you to have is try and look where patient payment performance is undermeasured, under-resourced, or misaligned with the affordability that actually is there for your patients today. So this is the kind of the end of the survey results we have here. We do want to quickly touch on how PayZen fits into this quandary, and then we'll jump into the questions that have been submitted over the last couple minutes. So we think of ourselves as an affordability platform. Our vision is to make care accessible and affordable for every patient. We are focused on patient centricity, dropping the barriers to financial options, and making sure that systems are really seeing the most that they can from that relationship, reducing the administrative friction, and increasing net collections for our health systems. So when we take a look at how we are designed to operate, we have a product suite that's designed to complement existing collection efforts. We never want to cannibalize higher yielding revenue. You've got your pay in full dollars. You have your in-house plans that particularly shorter plans tend to do quite well from a collections perspective. You have your financial assistance policies. We never want to cannibalize that revenue. Our focus is on how we're able to offer affordable options to patients that catches those folks who don't otherwise have a viable path. So we offer fee-free, interest-free, no extraordinary collections actions or collections ever payment plans, both pre-service, post-service. We'll touch on the offerings in a bit more detail in a second. And our key focus really is on patient centricity. We are fiercely proud of our industry-leading Net Promoter Score of 71, and we've delivered real value in for our systems. North of 30% average collections lift. That's true incremental value that we're delivering with significant increase in patient satisfaction. And we're doing that through a couple of different options today. We are a platform, not a point solution. We have products today that span the patient journey. So you have the care card, which is a pre-service access tool. So when the question your teams are asking is, how would you like to pay for that today? We want you to try and collect in full or take a down payment or get the patient set up on a payment plan. But when it's clear that your terms don't go out long enough, you can offer the care card where we're extending plans up to 60 months for patients, regardless of their credit eligibility. We will approve, we'll approve anybody. Then on the post-service side, we have our post-service payment plans. Again, that's that same always fee-free, always interest-free, 3 to 60-month payment plans that are available to patients who might not have otherwise paid in full or be eligible for shorter duration in-house plans. And then finally, we have our balance sheet boost product. So for those of you who are seeing these massive dollar amounts tied up in outstanding balances, we can actually take over servicing and set those plans up as a PayZen plan and be responsible for taking all of those plans over and advancing the cash into you. We primarily operate as a non-recourse vendor, meaning we assume all financial risk. And we believe that this is ultimately the best interest for patients since we have a industry-leading servicing team, domestically based, who's incredibly skilled at giving patients the flexibility that they need to ultimately pay down these bills, to ultimately maximize our collections and the yields back into the systems that we're able to pay. But we're at this really exciting juncture where we're dramatically expanding our platform. So on our roadmap to deliver this year, we have new tools around financial assistance automation, where we are going to support a lot of the really fragmented, challenging pathways, getting to patients faster and getting them into that FA flow. We have a Medicaid eligibility platform that we'll be releasing, as well as AI financial concierge, where patients can engage, ask questions, understand the breadth of options available to them. And all through this journey where we're seeing patients who are in the wrong funnel, the beauty is we'll be able to redirect them to the right place. So if someone's trying to sign up for a payment plan, should be going to financial assistance, we can redirect them seamlessly into that flow. And all of this is delivered in a best-in-class seamless integration into leading EMRs like Epic, et cetera. We use AI models for custom underwriting and are incredibly focused on patient experience. Our secret sauce really is we do a great job of understanding patient affordability at that individual level and making sure that we treat them as the individual with the unique circumstance that they have. And we've accomplished a lot with our partners so far. This is just a sample of the organizations that we work with today. And we're incredibly proud of the fact that we were named best in class this year in patient financing services. We're the only rated non-recourse option. So would love to chat with anyone about PayZen specific questions afterwards, but let's take a jump over into Q&A. Before we do that, please, you're welcome to download the full provider perspective report. We'll send all of this out to all of you after the end of the webinar as well. So let me jump over here really quickly, and let's see what we have from a Q&A perspective. All right, our first question we have, one of the most striking stats is that 72.2% of organizations do not know their default rate. In addition to default rate, what other KPIs should we be tracking around payment plans? So I think this comes back to what we were talking about a little bit earlier. How many patients are delayed or behind on those plans? How many of those patients are then getting back on track? So that delinquency, that slowdown in payments is a leading indicator of your defaults. But I'd really encourage everyone to be thinking about those other elements in the underlying unit economics of payment plans. So what's your payment processing cost? What's your true cost of capital? And thinking through, in conversation with generally your treasury team, that hurdle rate or investment rate, how much does it cost for me to be deploying those dollars here versus elsewhere? And then the final piece is what are the operational impacts? So for those of you doing this in-house, how much time are you spending talking to patients today, answering questions on plans, manually touching these plans, or if you're live on recourse financing, when those patient balances recourse back into you after a default with a third party, how much does it take to ultimately rehome those plans or send them through the collections process? That really all drives into the bottom line impact of supporting patients on those longer term plans. Next up, where do you see the highest value AI use cases emerging first? Any advice for a small system who wants to dip their toe into AI? This is an interesting one, and I don't want to inject too much personal opinion here. I think that self-service aspect where patients can ask questions and at their leisure when they need to. Everybody we know is always looking for now. How do I get the answer now? How do I get it when I actually have the time or can go through, kind of navigate at my will. If I'm asked a question, go get more information so that I can talk more about my personal circumstance. So those tools that have that persistence of who is the individual, that allow for a much deeper partnership and understanding in what that patient specifically needs, that allows them to navigate without waiting on hold to talk to someone through a call center. And I think provide like a more cohesive experience within the system. So a huge part of this is how does this sit within your brand or experience that you're looking to deliver? Obviously, we've seen Epic starting to move pretty aggressively in this space as they're keeping folks within the universe. But I think for a small system in particular, the most important focus is what are you trying to solve for? What is the single most important thing? Have that clearly in mind, clearly stated with the vendor, with a partner, and then make sure that you track that through longitudinally. There can be a lot of noise, a lot of exciting findings, but keeping in mind that North Star of what's most important can be a more approachable way to start this in the beginning. Next up, if we want, and this is our last question as of now, so if you have any more, please do drop them in. If we want more information on your product roadmap or PayZen, what's the best way to learn more? Please feel free to contact me. I'll jump over into this next slide here. My contact information is here. Feel free to shoot me an email. You can always reach out to our team or request more information off of our website. We'd be happy to go into more detail with you on kind of where we are in our view of the world. Let me pause here. Any other questions? I'll let it sit for a minute and then happy to give folks some time back on this Thursday. All right. Well, thank you so much, everybody. This has been great. Really appreciate you all taking the time. Look forward to continuing to share research like this with the market. And thanks again. Hope you have a great afternoon. Bye-bye.